Medurstand. Understanding Medicine.
I am Professor Azizur Rahman, and we are having a series of lectures on valvular heart diseases. I hope you have watched my earlier videos on aortic stenosis and mitral regurgitation and mitral stenosis. And this one is the last one in this series, and this time we will cover aortic regurgitation as the main condition, but in the same video I will also very briefly touch pulmonary stenosis and tricuspid regurgitation to complete this module of valvular heart diseases. So if you have not watched my earlier videos, I think it is recommended that you please watch them before you come here, because some of the basic concepts are discussed there. This one is the cartoon showing aortic regurgitation, and aortic regurgitation and aortic incompetence is the same. In a normal person, when left ventricle contracts during systole, it pumps blood into the aorta, and that blood never comes back because it moves forward. Immediately after the systole is over, these valves, the cusp, they move backward and they close aortic valve almost completely. So no blood comes back into the left ventricle. If aortic valve is defective and is incompetent and does not close properly, then some blood will come back as shown by this feather-like structure. So the blood will come back into the left ventricle, and this is called regurgitation. When in the start of diastole, there is very high pressure in the aorta, and in the pressure in the left ventricle is very low, so there is a lot of regurgitation. But as time passes, I mean a few milliseconds, then the gradient is reducing because pressure in the aorta is coming down and pressure in the left ventricle is building up. So there is less and less amount of blood coming back to the left ventricle. So during the mid of diastole, there is no further regurgitation and hence there is no murmur. So this will be referred to when we discuss the murmur also. This is the actual echo. You can see this blue jet of blood shows that the blood is coming back from the aorta to the left ventricle during diastole. And the principle of echo in Doppler is that they, depending upon the direction of the blood flow, they can give it a color. So this blue color actually means that the blood is flowing this way. So this is the basics. Now let's move on to the rest of the presentation. Etiology of aortic regurgitation could be rheumatic, as most valvular diseases are caused by rheumatic, but aortic regurgitation can also be due to other conditions like Marfan syndrome. Marfan syndrome is a congenital disease where there is a problem with connective tissue, and people are typically very tall and they may have defective connective tissue. These valves are also made of connective tissue, and this could result in aortic regurgitation and sometimes also dissection of aorta. Endocarditis, you all know that endocarditis damages valve, and if somebody has endocarditis due to whatever cause, and the valve could be damaged and it could also result in endocarditis. Syphilis used to be a common condition. Luckily, it is not common anymore. In fact, I doubt it even exists. It definitely exists, I believe, but only in the form of acute syphilis. Previously, syphilis used to lead to a lot of systemic complication, including valvular disease. Luckily, we don't see any valvular disease due to untreated syphilis. Then degenerative, like other tissues, the valve tissue also degenerates, particularly those patients who had aortic valve disease, bicuspid aortic valve disease, and later on, because of shear forces and because of the stress on the valves, it could actually degenerate and can lead to regurgitation. But by far, the commonest is rheumatic. But one thing which I always emphasize, that whenever you have aortic valve disease, which is due to rheumatic, most probably you will also have some mitral valve disease. So that would actually give a clue. In case of Marfan syndrome, you may have just aortic valve disease. The mitral valve will be normal. But if there is mitral valve disease and additional aortic valve disease, then most likely the cause would be rheumatic. The symptoms may be none. Sometimes these patients are just incidentally diagnosed, but the main symptom is palpitation because these patients have increased stroke volume, and because of left ventricular hypertrophy, because of the very dynamic left ventricle, there may be palpitation. And if the heart fails, which of course ultimately any valvular disease can lead to heart failure. If that is the case, then patient might develop dyspnea. But none of these symptoms are specific to aortic regurgitation. Of course, from the stature of the person, sometimes you can guess that this patient is likely to have Marfan syndrome, and then patient is likely to have valvular heart disease in the form of aortic regurgitation, but no symptom is actually very specific to aortic regurgitation. Now, physical signs are important. Some physical signs can give you a very strong clue to the diagnosis, or it can give you the actual diagnosis. First, of course, is the pulse. As per normal examination techniques, whenever you examine cardiovascular system, you first examine pulse, then you take blood pressure, then you examine neck veins, and then you come to the precordium. So if you start with the pulse, now one feature of the pulse is that it may be collapsing in character. What is exactly collapsing? I'd like to explain. It has got several features. Number one, it is high volume. And what is high volume? You need to examine a couple of patients, maybe dozens of patients, to know exactly what is normal volume. So if the volume of the pulse is more than that, it would be called high volume pulse. Of course, there are other causes of high volume pulse, but one of them is this aortic regurgitation. And there are four components. Only then you can say that this is a collapsing pulse. One of them, the first one, is high volume. Then there is very rapid upstroke and very rapid downfall. So very narrow pulse, but it becomes narrow means if you draw this, it would be narrow, but it will have high amplitude. So it's a pulse which is high volume with very rapid upstroke and very rapid downfall. So this makes three components. The fourth component, the most important component, is if you examine the pulse and then with your other hand raise the arm like this, and then you are holding the wrist like this, you are concentrating on the volume of the pulse. When you raise the arm, the volume of pulse increases further. Now this is where most students, they make mistake. They just make a guess that collapsing pulse would perhaps mean that the pulse collapses and the pulse disappears. Actually, the volume of the pulse increases further when you raise the arm. Why so? Because the effect of gravity is added. Now, I think we have to explain why there is a high volume pulse. Only then you would understand this collapsing pulse. Please bear with me. I'm going to explain why there is a high volume pulse in aortic regurgitation. Actually, left ventricle is receiving more than usual venous return. It is, of course, receiving blood from the left atrium like a normal person, but it is also receiving blood from the aorta because the aortic valve is incompetent. Some of the blood from the aorta, which was actually supposed to go further down to the peripheral circulation, comes back to the left ventricle. So left ventricle is overfilled. It is receiving blood from the left atrium as well as aorta. So it is receiving more blood. That means left ventricle has got volume overload. So as per Starling principle, left ventricle will contract with greater force and will produce more stroke volume. So that would result in a higher systolic pressure because the stroke volume is high. The systolic pressure will go up, and because the blood leaks back into the left ventricle, so the diastolic pressure drops. So this is a situation where systolic pressure goes up, diastolic pressure goes down, resulting in wide pulse pressure. And the pulse pressure actually determines pulse volume. So that explains why there is high volume pulse in aortic regurgitation. Now I will explain why the volume increases further when you raise the arm. When you raise the arm, the effect of gravity is elevated. So there is more regurgitation, more blood comes back to the left atrium, leading to even greater stroke volume and leading to even further rise in systolic blood pressure and further drop in diastolic pressure. So that is explanation of high volume pulse, which further increases on raising arm. So this is so important, and if you pick up this collapsing pulse, then the diagnosis of aortic regurgitation will be very easy. The murmur of aortic regurgitation can be easily missed, but if you have gone methodically, if you have examined pulse properly, and if you have picked up the pulse of aortic regurgitation, by the time you reach precordium, you would be actually already anticipating the murmur of aortic regurgitation, so you will not miss it. I hope I was able to make this point clear. Then there is heaving apex beat. Apex beat would be displaced. Normally, apex beat is felt in the fifth intercostal space, just medial to the mid-clavicle line. But in cases of left ventricular hypertrophy, it would be displaced leftward and downward. So it may be felt in the sixth intercostal space and in sometimes seventh intercostal space and lateral to the mid-clavicle line, maybe sometime even lateral to the anterior axillary line. So number one, apex beat will be displaced downward and outward. Number two, it would be heaving. What exactly is heaving? When you put your hand on the precordium, you would feel as if your hand is being lifted with every systole. Now this would be called heaving, and it is actually a ill-sustained heave. Heave is also of two types, ill-sustained and sustained. In this case, your hand will be lifted, but it will immediately go back because it is ill-sustained. Uh, as against the heaving apex beat I described in aortic stenosis. In aortic stenosis, it takes much longer for systole to complete and the heave is sustained. Whereas in aortic regurgitation, the heave is actually ill-sustained. Then this is the most classical thing, the murmur. But I must confess that this murmur is very soft and very faint, and you need to be an expert and you need to have a quiet environment and you have to be very, very vigilant, you have to concentrate with full attention, only then you will be able to pick up this murmur. Second thing is this murmur is best heard with the diaphragm and patient is sitting up and you ask the patient to lean forward when you auscultate the patient, and I think even to make it better, you ask the patient to hold the breath. Take an inspiration and hold the breath there. Of course, it would be for a few seconds only. So I think when you are coming to the auscultation, you can do that procedure to pick up this murmur. This murmur is early diastolic and is decrescendo. Early diastole because in the initial part of diastole, there is significant gradient between aorta and left ventricle and the blood regurgitates back into the left ventricle. Decrescendo means something which decreases with time. So within few milliseconds, the intensity of the murmur will decrease. Why? Because the gradient, the pressure gradient, the driving force for the regurgitation of blood is reducing. Pressure in the aorta is coming down and pressure in the left ventricle is building up. So the actual gradient is reducing. So, and by the mid of diastole, there is no gradient and there is no further regurgitation, the murmur ceases. So I'll show you by this graph also. And this murmur is very, very soft in intensity and in character, so to differentiate it from the murmur of aortic stenosis and VSD, which are very harsh and loud. Best heard at A2. A2, I'm sure you know the A2 area is third intercostal space left to the sternum. Okay, so that is the area where murmur of aortic regurgitation is best heard. And best heard when you are examining with diaphragm, and patient is sitting up with holding his breath during expiration and bending forward. If you have examined the pulse and if you check the blood pressure, and blood pressure would show wide blood pressure, there may be systolic blood pressure may be up, down, diastolic pressure may be might have gone down, so leading to wide pulse pressure. If you have done that, you would actually pick up this murmur very easily. And sometimes there may be Austin-Flint murmur. Now, what is this murmur? This is, if you remember that cartoon I showed in the beginning, when there is regurgitation of blood, the blood comes back from the aorta to the left ventricle. It actually passes over the anterior mitral leaflet. When it does that, it might put the mitral valve into vibration like this. So the mitral valve, the anterior leaflet of mitral valve, it flutters or it goes into vibration, producing a murmur which appears to be coming from the mitral valve. So it might mimic the murmur of mitral stenosis. This is actually a mid-diastole murmur coming from the mitral valve, but not indicating mitral stenosis. It is due to the regurgitation of the blood into the left ventricle. So in the first time it was described by Austin and Flint, so that is why it is called Austin-Flint murmur. There could be, you could actually confuse it with actual mitral stenosis. Of course, an echo would be able to help you out. So these are the classical physical finding, but most important is the pulse and the blood pressure, and then of course this murmur. This cartoon will show you how this murmur is. This is normal person, systole and diastole. This is the first sound, the second sound. The second sound consists of two components, and the murmur is like this. Early diastole murmur. See this decrescendo murmur. The maximum to start with, immediately after the second sound, immediately the diastole starts. The murmur is there. Murmur is has the maximum intensity to begin with, but as time passes and during the mid of the almost up to the mid of diastole, there is no further murmur. So this is decrescendo murmur of aortic regurgitation. Early diastolic murmur. EDM is early diastolic murmur. Differential diagnosis of collapsing pulse. I think the collapsing pulse is seen in its most typical form in aortic regurgitation. I would call it pathognomonic of aortic regurgitation, but of course there are some conditions which could cause this pulse, which is very much like a murmur of aortic regurgitation. AV fistula. It could be congenital arteriovenous fistula, or more likely somebody has arteriovenous fistula made for dialysis. Why so? Because in normally from the arterial system, blood goes to the venous system only by passing through the capillaries, which takes some time. But if there is a free communication between artery and vein, blood will quickly go from the aorta, one of the branches of aorta, to the venous side. So it will produce the same hemodynamic effect as blood regurgitates back into the left ventricle. PDA, patent ductus arteriosus, can also cause high volume pulse. Paget's disease of bone, there's a disease which is actually primarily that of bone, but in that there is a lot of new vessel formation. There is many small arteriovenous communications, so that would also cause the same effect. Hyperthyroidism, it would cause at least high volume pulse, if not the classical collapsing pulse. Anemia, pregnancy, so they all can cause high volume pulse. Diagnosis, first of all, clinical. I always emphasize the clinical examination, and I think it is an extremely rewarding experience to be able to make a clinical diagnosis and later on finding on an echo that your judgment was correct. So I think don't deprive yourself of that feeling. Develop your clinical skills to make a proper diagnosis. So clinically, I think collapsing pulse and early diastolic murmurs with the dynamic precordium. These are classical signs we have already discussed. On XHS, you would have some cardiomegaly of left ventricular type. Cardiomegaly could be due to several types. There is a specific type which we see in pericardial effusion. Then there is a specific type which we see in right ventricular hypertrophy. Then there is the type which we see in left ventricular hypertrophy. In left ventricular hypertrophy type, in fact, left ventricular dilatation more than hypertrophy, the apex moved leftward and downward. So that is the type of cardiomegaly, and sometimes if patient has got heart failure, you might actually see some pulmonary infiltrates also indicating pulmonary edema. On ECG, you may see left ventricular hypertrophy. Left ventricular hypertrophy is represented in ECG by tall R waves. Now, I would have a separate module on ECG, so here I would not be able to go into detail, but just one thing, that in limb leads and in the precordial leads, R wave and also the corresponding S wave, they have increased amplitude, and there are certain specific numbers. If those numbers, if the amplitude is above that, you can make a diagnosis of left ventricular hypertrophy. But we all agree that echocardiography is much more sensitive than ECG, even to pick up left ventricular hypertrophy. But echo is actually going to show you much more. On echocardiography, with echocardiography, of course, Doppler will also be done. You can get final diagnosis. You can be sure if there is additional aortic stenosis, and if it is aortic regurgitation, you can actually quantitate the amount of regurgitation. You can pick up additional valvular diseases, you can pick up endocarditis, you can pick up a clot. So I think definitive diagnosis of aortic regurgitation requires a proper echocardiography. That is very, very important. And luckily, this is a non-invasive test, although you need a relatively expensive equipment and a very trained personnel to make an echo. But of course, this is very, very useful test. Treatment of valvular diseases, first of all, I think wait and see, and of course it is a structural abnormality. You might be surprised why we would like to wait and see. There are people who may not have symptoms, the symptoms are minimal, and I think I would just like to keep an eye on them and see how they behave and how they I mean, if they deteriorate or if they remain stable. Of course, they would require a regular follow-up. And valve replacement, if the valve is damaged, I'm afraid there's no other solution. If the left ventricle is failing and if a valve is badly damaged, you would probably need to replace it with prosthetic valve or cadaveric valve. All patients with the valvular heart diseases, they require endocarditis prophylaxis. This concept has been discussed, so I'm not going to discuss it again. Endocarditis prophylaxis would be needed. Similarly, thromboembolic prophylaxis with warfarin. This has also been discussed earlier, so I'm going to just skip the details. These two things would be given to all those patients, and if patient is even slightly symptomatic, I think you should not wait. Of course, I understand valve replacement is not easy. It's going to be expensive. It is going to require lifelong therapy. Even after the replacement, patient would need lifelong anticoagulant therapy. But it is important because once left ventricle fails, then even replacing the aortic valve might not lead to significant improvement in patient's life. Uh, since aortic valve disease, the rheumatic process especially damages valve, it is very much possible to have a combined lesion. A patient with combined stenosis as well as regurgitation. It is very unlikely in patient with Marfan syndrome, but stenosis and regurgitation is combined lesion is likely in two situations. Number one, when there is rheumatic valvular disease. Two, when there is patient actually had bicuspid aortic valve disease, that may also cause stenosis and regurgitation. Remember one thing, patient with pure aortic regurgitation may also have a systolic ejection murmur, which is functional, which is not actually due to stenosis, it is functional that because stroke volume of left ventricle has increased many times, and because of that there is more flow across the aortic valve, and that just produces a sound which is a systolic ejection murmur, but it is not indicative of aortic stenosis. So excluding that, there could be actual stenosis and regurgitation, and this is the murmur you will see. So of course you will have two murmurs. This is systolic ejection murmur with its feature. The feature is very harsh and loud murmur, best heard in the aortic area and radiates to the neck. And this is an early diastole murmur, which is a diastole murmur and is soft and is best heard on the aortic 2 area and does not radiate to the neck. So you will have both these murmur in one person. You can suspect a combined aortic stenosis and aortic regurgitation. As I said, I'm going to also discuss tricuspid regurgitation and pulmonary stenosis also, this very briefly, because we have discussed uh, mitral regurgitation. More or less the same complex concept will apply here. Usually, tricuspid regurgitation is secondary to right ventricular dilatation due to pulmonary hypertension. There are many causes of pulmonary hypertension. Pulmonary hypertension can be a disease of the lung itself, or could be idiopathic, or could be secondary to left-sided heart disease. This would cause right ventricular dilatation, and right ventricular dilatation will lead to functional tricuspid regurgitation. And it has got the same character. The murmur is same character as we see in mitral regurgitation. It is soft and blowing. It is best heard on the left lower sternal border, somewhere here. That is the area, and it does not radiate to the axilla. And there may be V wave on the examination of neck. What is V? Actually, it is the ventriculization of neck veins. You normally also have a small V wave, but in cases of tricuspid regurgitation, because there is actual regurgitation of blood from the right ventricle into the right atrium and then back into the neck veins, so you get a huge wave. Normally it is just the displacement of the tricuspid valve into the tricuspid valve apparatus into the right atrium, which just raises pressure very minutely. But in cases of tricuspid regurgitation, you actually see the vein pulsating. So this is actually a right ventricular arterial pulse which is felt in the vein. Then you may also have a classical finding of pulsatile liver. There are several causes of enlargement of liver, but if liver is enlarged and pulsatile, by that I mean when you put your hand on the liver, you will feel that with every systole it expands. Very interesting finding. In the proper context, presence of pulsatile liver would indicate tricuspid regurgitation. So I think most these patients would require treatment for their primary disease, pulmonary hypertension and left-sided disease. The tricuspid valve itself does not usually require a treatment. Uh, Regarding previous slide, there are some situations. I mean, there used to be some anti-obesity drug which led to tricuspid regurgitation, and also in carcinoid syndrome there could be selective right-sided disease and tricuspid regurgitation. This is an exception to what I said, that mostly it is due to pulmonary hypertension. Now let's very briefly talk about pulmonary stenosis. Just like aortic stenosis, usually the murmur is the same, and it is usually congenital, not rheumatic. Murmur same characters as aortic stenosis, but it would not radiate to the neck. It is best heard around the pulmonary area. Pulmonary area is second intercostal space, right to the sternum. Or is it left? I think it's right. Yes, second intercostal space right to the sternum. That is a pulmonary area. That is where it is best heard, and it would not radiate to the neck. And treatment is usually with balloon. Luckily, this congenital disease is very amenable to the treatment of balloon. So these patients can benefit from this without having to undergo open heart surgery. So that is it. This is Professor Azizur Rahman from Medurstand. So with that, I conclude my series on valvular heart diseases. I have covered mitral stenosis in detail. I have covered mitral regurgitation in detail, aortic stenosis in detail, aortic regurgitation in detail, and briefly pulmonary stenosis and tricuspid regurgitation. Of course, there are some other valvular disorder that you can read from the book. I hope it was useful. Please join me uh, later in my next series, which is going to be on ischemic heart disease. Till then, look after yourself. Thank you very much. Professor Azizur Rahman from Medurstand.